Amazing and awesome cases are going to be the next several talks. The first person is going to be Dr. Yashi Yathindra, then Mike Mish, because we like alliteration with our amazing and awesome, and then Robin Schaefer. So Yashi, a long-serving originally resident member of the committee, and our boss, our Amna Karabagova, is taking off the chair. Thank you very much. Okay, Yashi's going to come talk to you about an amazing and awesome case.
Yeah. Can everyone hear me? All right, so we're in the home stretch of this incredible conference, and I'm so excited to be part of this segment called Amazing and Awesome Cases. The next hour is truly a celebration of emergency medicine, of you, our emergency healthcare providers, and everything that you do on a daily basis to help our patients. I have no conflicts of interest to disclose. So 5 years ago, I actually presented our first ANA case rounds at North York General Hospital. And they were inspired by this article by Dr. Lisa Fisher, who is an Emerge doc in Ottawa. In the article, she talks about a case that she saw in the emergency department. A gentleman is found passed out in his vehicle by a bystander. EMS is called. The gentleman perks up on his way to the emergency department, and he's able to tell Dr. Fisher that he had sudden onset abdominal pain and dizziness, so he pulled over to the side of the road. She immediately does a bedside ultrasound, discovers a 9 by 9 centimeter AAA, calls her closest vascular site, and the patient is in and out of the department within 20 minutes. The next day, she gets a text from her ICU colleague, and it says, "Congratulations, this guy would have died if it weren't for you." Apparently, on the way up to the OR in the elevator, he suffers a cardiac arrest, requires 10 minutes of CPR, a non-sterile laparotomy, and an infrarenal aortic clamp, and he survives. Initially, she gives all the credit to the surgeon, the anesthesiologist, the ICU team for saving this guy. But you know what? She quickly realizes she feels pretty good too. Because if it wasn't for the quick actions of her and her emergency medicine team, this guy would be dead. It's pretty rare that we pat ourselves on the back for a job well done. When was the last time you congratulated yourself for resuscitating the septic patient, for picking up a STEMI on an ECG, for helping a patient who's struggling with IPV? We don't celebrate or congratulate ourselves, so maybe it's time we started doing that for each other. We could thank each other more, we could appreciate each other more, we could lift each other up more, and we can celebrate each other's successes more. So the goal for ANA cases today is to celebrate. Celebrate good practice highlighted by clinical cases, teach around those cases, and maybe identify a few factors that contributed to what worked well. Back in January, we put out a tweet asking for the ANA cases of the EM community. So for our first case, I want to take you to Michael Garron Hospital, formerly known as Toronto East General Hospital. Michael Garron is a busy community academic center located in Toronto, about 30 kilometers northeast of where we are right now. Their emergency department sees about 240 patients per day, the majority of whom are considered complex. And they have most services and specialties available to them during the day, but they don't have trauma, neurosurgery, and vascular surgery. Before we get started with this case, I want you to know that the emergency physicians involved did obtain permission from the family for me to present this case to you today. All right, let's get started. Okay, it is a weekday afternoon, 2:45 p.m. An unexpected code pink emergency department resuscitation room goes off overhead. 3 Emerge docs go running. They find a 5-month-old baby boy in his father's arms who is pale, floppy, and has weak respiratory effort. There's no history available. Parents brought this child in like this. There's no triage assessment, no triage vitals, but the resuscitation had to begin immediately. One of the Emerge docs did a jaw thrust, another went and grabbed the BVM, started bagging the patient in the father's arms. They put the baby on the stretcher. identified a pulse, and applied all the monitors. I'm going to give you the history of what happened to this child so you can appreciate it, but the emerge docs didn't know this right away. So this is a previously healthy 5-month-old baby boy who earlier that day fell off the bed onto a carpeted floor and hit his head. There was no loss of consciousness. He was crying right away. Mom did a quick Google search, checked his pupils. They were equal. He was cooing, he was alert, parents weren't concerned. They actually booked a virtual appointment with the Michael Garron Emergency Department at 4 p.m. Thankfully, the virtual care emerge doc working that day saw the chief complaint, called the family, said, this isn't appropriate for virtual care. Please come into the emerge for a formal in-person assessment. And between the time of that call around 2 p.m. and then 2:45 when they presented, baby became more lethargic and vomited once en route. This is the physical exam. So like I said before, baby was pale, floppy, GCS of 3, with weak respiratory effort. Baby was bradycardic, hypertensive, and profoundly hypoxic. They noted the left pupil was dilated at 6 millimeters, and the right pupil was 2 millimeters. And there was a large, boggy, left posterior parietal scalp hematoma. The rest of the physical exam was unremarkable. So within minutes of this patient presenting, the emergency docs had their diagnosis: epidural hematoma with possible uncal herniation. I want to take a step back and just review how they got there. So first of all, children with hematomas that are worrisome for underlying skull fractures and bleeds are ones that are boggy, non-frontal, and greater than 2 centimeters in size. Now, if a child is presenting with signs of increased ICP, they'll have signs and symptoms depending on their age: headache, vomiting, hypertension, papilledema, blurry vision, etc. But if they're presenting with signs of impending herniation, now you're going to see things like progressive obtundation, unilateral pupillary dilatation, and Cushing's triad, which we talked a little about yesterday as well with Dr. Lin's talk. And Cushing's triad's combination of bradycardia, hypertension, and abnormal respiration. This is how the child presented, and this is why the emerge docs were not only worried about a bleed, but about potential herniation. So before we move on to see what happened next at Michael Garron, I just want to give you a few pearls around the treatment and management of a child presenting with severe head trauma, which is classified by the Canadian Pediatric Society as a child with a head injury and a GCS of 8 or less. Many of these pearls were derived from the TREC severe head trauma recommendations. All right, so you have a child who's presenting with a severe head injury. First of all, you want to do your full trauma assessment, right? You're going to do your primary and secondary survey. You're going to immobilize that C-spine, and you're going to treat any other obvious major injuries that you have. But once you've identified that they have a traumatic brain injury, the goal is to prevent secondary brain injury. And you're going to do that by maintaining your cerebral perfusion pressure and by avoiding hypoxia. If you can remember that your cerebral perfusion pressure is equal to your mean arterial pressure minus your intracranial pressure, you'll understand that we need to avoid hypotension by giving fluids, by giving pressors, potentially giving blood if they're hemorrhaging from another site. And we need to decrease that ICP. So to prevent secondary brain injury, we want to avoid hypotension, decrease that ICP, and avoid hypoxia. Using these pearls, let's talk about 2 important aspects of management in a patient or a child with severe head trauma. So first of all, if your child is presenting with signs of increased ICP, no signs of herniation, you want to elevate the head of the bed to 30 degrees, and you want to give them an IV hyperosmotic agent. that will reduce the ICP. In the pediatric population, IV hypertonic saline is preferred over mannitol. It's easy to use, it's readily available, and there's more evidence to support its use in the pediatric population. Okay? Now, if your child is presenting with signs of impending herniation, in addition to these two measures, you're also going to want to hyperventilate them to an end tidal CO2 of 30 to 35. Hyperventilation causes hypocapnia, which causes cerebral artery vasoconstriction, which decreases overall blood volume in the brain, which decreases ICP. But cerebral artery vasoconstriction can also lead to ischemia, which is why we reserve hyperventilation for the patient who has impending herniation. If you haven't given mannitol yet, and none of these other measures seem to be working, you can also add it in at this point. All of these patients, pediatric patients with severe head trauma, they will need to go to a neurosurgical site for definitive management. But if you feel that they may complete their herniation before they reach that tertiary care center, you're obligated to at least talk to the neurosurgeon about manual decompression with burr holes. That's a totally different talk. We're not going to talk about that right now. But please, please, please make that call and talk to them about it. All right, let's talk about the airway very quickly. So all of these patients, GCS 8 or less, we need airway protection in the form of intubation. You need to maintain your C-spine precautions, and you're also going to want to avoid hypoxia. Intubation is a high-risk time for hypoxia. So we're going to pre-oxygenate all of these patients, and we're going to have our most experienced provider intubating them. If your patient is peri-arrest, you don't have time, you don't need medications, just get that tube in. But if you have a couple of minutes to do an RSI, consider fentanyl as a pre-induction agent, which may help blunt that increase in ICP associated with intubation. Ketamine is going to be your go-to in terms of induction agent because it maintains your blood pressure better. It does not increase your ICP, and there is some literature to support that it is neuroprotective in children. And then finally, for your paralytic, you're going to use rock or sucks. All right, so why don't we go back and see what they did at Michael Garron. So they got their diagnosis. They immediately immobilized that C-spine with 2 rolls taped to the side of the baby's head. They elevated the head of the bed to 30 degrees. Anesthesia came down with the code pink, intubated that baby on first pass with glide scope, no medications were used. They hyperventilated the baby to an end tidal CO2 of 30. There was some mechanical ventilator issues, so the RT actually had to bag the patient, manually ventilate that patient. They had some challenges with IV access. Baby was quite chubby. They attempted an IO on the right side, a pediatric IO, which was unsuccessful. So they ended up putting an adult IO on the left tibia, which was successful. They pulled out their Broslow tape, which is going to be crucial in pediatric resuscitations, and they used it for medication dosages. They gave a dose of hypertonic saline through the IO. Patient had a bit of a post-traumatic seizure, which is treated very much like acute seizures, and a dose of lorazepam was given through the IO. The pediatricians were there. They were liaising with Critical, which is the service available in Ontario to access specialists that don't exist at our site. So there was a team from the Hospital for Sick Children on the other end of the phone. The lead emerge doc brought up the idea of potentially like burr holes and when to do them, but the neurosurgeons didn't think it was recommended at this time. A portable chest x-ray was done, which didn't show any signs of chest trauma. And a CT head and C-spine were done as well. The RT continued to bag the patient while they were in the scanner. And just a note here that CT head is not required for the diagnosis, and it's not, it shouldn't delay transport. In this case, they had time, so that's why the patient went. I want to show you the CT head. So there's a left parietal bone fracture with overlying scalp hematoma, large epidural hematoma with significant mass effect in midline shift, no uncal or cerebellar tonsillar herniation, and no C-spine fracture. Shortly after 4 o'clock, while the patient was in the scanner, the transport team arrived, picked up baby, took him to the hospital for sick children. And in that hour and 20 minutes that this patient was at Michael Garron, he got the best possible care to ensure he had the best possible chance of survival. So let's see how he did. He went to the hospital for sick children, where he underwent neurosurgery, and he survived. He went to the ICU for a few days, and he survived. He went to the observation floors and then to rehab and home. And now our baby is 11 months old, cognitively intact, moving all of his arms and legs, has a little bit of residual weakness in the right arm, which they're working on. He can pull to stand. He's happy and healthy. He's the joy of his parents' lives. And the mother still keeps in touch with one of the Emerge docs to give her updates on how her son is doing. And he's doing really, really well. So why did this case go so well? First of all, the Emerge docs were medical experts. They took charge of this case. They ran a beautiful resuscitation despite some of the challenges that they faced. It was excellent. The RT, completely heroic, selfless, willing to be irradiated to help her patient. The biggest reason that this case went well, according to the Emerge docs, though, was teamwork. There were a lot of people in that room, but everyone had a role and a responsibility, and they did it to the best of their ability. They listened to each other. They listened to the team leader. There was excellent communication. The Michael Garron Emergency Department actually has an in situ sim program where they work on teamwork and communication on a regular basis, and I don't doubt that this helped. In fact, it's something maybe all of our emergency departments should consider instituting. And then finally, having critical for life or limb transport was also crucial to this case. So the two sort of take-home points I want to get across are if you have a pediatric patient who comes in with a traumatic brain injury, everything you do should revolve around the goal of preventing secondary brain injury. And finally, an excellent emergency medicine team is always going to be more successful than any individual on their own. So it is my pleasure to reveal to you the 3 emergency physicians who saved this boy's life. Please, please, please put your hands together for Dr. David Rosenstein, the lead Emerge doc, Dr. Megan Reynolds, and Dr. Angela Morocco. Dr. Rosenstein and Dr. Morocco are in the audience today, so please give them a high five and a congratulations after the conference is done. But like I said before, this was a complete team effort. So I want another big round of applause for all of the nurses, the RTs, the support staff, the EMS crew, the specialists who were involved in saving this boy's life. So I think my time is officially done. Thank you for everything that you do. It is an honor and a privilege to be your colleague. Cheers.
Thanks, Yashi.